Thanks, Shiva, for that kind introduction. And I've been asked to speak on complex ASD device closure tips and tricks. Really, I'm exhausted with all tips and tricks. So those of you who have listened to me earlier probably may take off and have a cup of tea or coffee. Most of the tips and tricks are known to you, but just to recapitulate some of them and probably discuss some of the indications where these tips and tricks could come handy. The most important question is, why do you need these tips and tricks? And the answer is very simple. Routine technique does not work in all the patients all the time. Even in the so-called simple cases, you may be successful in maybe 75 to 80% of the cases using the routine technique of deployment of the ASD device. And if you look at the more complex cases, I think the success rate would drop down to 50%. So definitely there is a role for knowing tips and tricks. Now the thing is, which are the conditions where there is a likelihood of failure? So when you deal with large ASDs in adults, like ASDs more than 34 or 35 millimeters, or large ASDs in children, where the device size is more than twice the weight of the child in kilograms, or those associated with rim abnormalities. And the whole problem is that these large ASDs are not uncommonly associated with rim abnormalities. And these include just adequate rims, or what we call as deficient rims, or floppy rims, or malaligned rims, where there is a malalignment of septum primum and secundum. Some of the clinical issues can also make device closure technically quite demanding, and they include spinal deformities or cardiac malpositions like dextromesocardia, or those with congenitally corrected transposition of great arteries. Now, no matter how many tips and tricks you know, if you see a ASD like this, which is humongous in size, 38 millimeters, with hardly any rim on the posterior superior aspect, hardly any aortic rim, no posterior inferior rim, and probably the SVC and IVC rim are also absent. Now, this ASD, you just cannot close given the current technology. So you cannot close this in the cath lab, and you necessarily need to send this patient to the operating room. However, I'll show you some of the examples of large ASDs which can be closed in the cath lab. So this is one such case where the ASD is around 38 or 39 millimeters in 4-chamber view. And if you look at the short axis view, it comes down to nearly 40 millimeters. Now, this is another example of a very large ASD which we closed in the cath lab, was measuring around 38 to 39 millimeters. And these are the examples of large ASDs in children, which can be closed, in the cath. Child with the ASD, which was measuring around 17 millimeters. Now, these are some of the examples of rim abnormalities. This is the absent aortic rim, which is not uncommon, and it's not a very demanding situation for using tips and tricks. This is an example of a deficient SVC rim here. This is an example of a deficient posterior inferior rim here. And this is an example of a deficient IVC rim here. And all these patients were closed successfully in the cath lab. Now, this is an example of what I call as a floppy rim. You can see the septum primum, which is quite floppy and redundant. And when you have a defect which is reasonably large sized, then probably these floppy rims can come in the way of technical success. If you have a small defect with a floppy rim, probably you may get away. But when the defect is large, at that time, probably you may need to use some of the tips and tricks. And this is an example of what I call as malalignment. This is a septum primum, septum secundum. You can see the malalignment in short axis. This is a malalignment in 4-chamber view. And this is a huge malalignment between septum primum and septum secundum. You can see the amount of malalignment in the bicaval view. So these are really very demanding cases. And some of them you may actually fail despite using all tips and tricks. So if you look at all these cases, I think there are two basic mechanisms which result into failure of the routine technique of device closure, opening the LA disc just outside the left superior pulmonary vein, and then bringing the device back, and then opening the waist and the right atrial disc. The most important mechanism is inability to align the left atrial disc with the interatrial septum, and that's common in adults. And more common in children is inability to accommodate the left atrial disc within a small left atrium, especially in children with large ASDs. And this inability to accommodate the left atrial disc results into secondary malalignment, and the whole device actually herniates across the defect into the right atrium. So this is an example of inability to align. You can see this is the left atrial disc. This is the plane of the interatrial septum here. So instead of the disc aligning itself with the plane, it is almost perpendicular to the plane of the interatrial septum. And this can really be sometimes a pain in the neck. And every time you open the disc, it kind of malaligns itself with the plane of the interatrial septum. So what are the solutions that you have? You can change the mode of delivery. Instead of coming from outside the left superior, you can come from outside the right superior. You can change the delivery sheath, or you can use an additional support. And all these three things can help you in getting, acquiring the technical success. So this is an example of the left atrial disc being opened just outside the right superior pulmonary vein instead of the left superior pulmonary vein. And we were successful in aligning the left atrial disc with the plane of the interatrial septum. Then we released the waist and the right atrial disc. And once the device was in good position, we have released this device. As I said, you can change the delivery sheath, either use Hausdorff sheath or a side cutting or a Fustar sheath, so that you can align the left atrial disc properly. And then there are people who have used multiple additional supports, guide wire, diagnostic catheters, guide catheters, long dilators. And as all of you are aware, that we are fond of using the sizing balloon for supporting these large defects. So this is an example of a 39 millimeter defect, which requires a 40 millimeter device. And you can see this is the circular balloon coming from the left femoral vein. And this is a 14 French delivery sheath coming from the right femoral vein. Then we inflate the balloon and just jab it across the interatrial septum, then open the left atrial disc. And you can see that this balloon prevents the herniation of the disc across the defect and gives you enough time to really release the waist and the right atrial disc. So you don't have to be in any form of hurry. And once you have delivered the right atrial disc, then you can slowly deflate the balloon, and the device forms beautifully across the interatrial septum. Once you're happy, then you can remove the balloon, followed by removal of the wire. And once you're happy with the lie of the device fluoroscopically as well as on transesophageal echo, then you can release the device. So this is a 40 millimeter device closing a 38 or a 39 millimeter defect. The same technique was modified by the French group, and they used the same balloon, but instead of placing it at the level of the interatrial septum, they pushed it a little further into the left atrium and probably got similar kind of result with a technical success of nearly 98 to 99%. However, there are problems with equalizer balloon. It's a very large profile balloon. The tip is not pointed, and that's why getting it through the skin and subcutaneous tissue, especially in children, can be quite challenging. Hemostasis is an issue because many times these large balloons with blunt tips can cause some trauma to the vein. And lastly, the tip of the balloon is such, and the de-airing port is such that it's not very easy to de-air this balloon. Lastly, this balloon is not very easily available. And that is why I think Wahab and his colleagues started using the sizing balloon from Amplitude. And what we have seen is that over the last 5 to 6 years, we have also moved on to using the Amplitude sizing balloon, and you can use it as safely and as effectively, if not more effectively and more safely than the equalizer balloon. So this is that large ASD measuring around 38 millimeters. And you can see that most of the rims are just a small, tiny sliver. You can see this, even the IBC rim, and this is the 3D picture. And you can see it's a huge hole with just a little bit of a rim around there. So with the help of balloon assist, probably you will be able to position the device reasonably well. And this is that elongated balloon. This is the left atrial disc, which is a 40 millimeter device. That's the waist and the right atrial disc. And then we deflate, and you can see that the device is sitting beautifully. The beauty of this technique is that it is a very predictable technique. You don't have to mess around recapturing the discs and keep on redeploying the discs. Most often within 1 or 2 attempts, you are able to get the device in position. And because this patient was little elderly, we had to perforate the device in the cath lab, and you can see the posterior-inferior perforation, and this is the anterior-superior perforation, and this is in the bicable view. You can see the inferior perforations rather well. This patient did brilliantly, came to us in NYHA class 4, and almost walked out of the hospital. So this is one of the largest ASDs in a very small kid. This is a 6.3 or a 6.4 kg child with a 17 millimeter defect, but the surrounding rims are quite good. So we decided that we are going to use a device and try and close this. This is a 18 millimeter balloon stage diameter. So we decided to use a 18 millimeter device, and the same sizing balloon was used to assist. So this is the 18 millimeter amplitude septal occluder, balloon in position. We are slowly releasing the waist and the right atrial disc. But when we try and push the right atrial disc while deflating the balloon, sometimes the right atrial disc may get pushed across the defect and go into the left atrium, as it happened in this case. But the beauty is that the left atrial disc was so well aligned to the plane of the interatrial septum that our job was simple: just recapture the waist and the right atrial disc and deploy them all over again. And then this is how it looks. Once we are happy with the position on transesophageal as well as fluoroscopy, we have released it. So this is the 18 millimeter in a child who is around 6.3 or a 6.4 kg. Now, this is the second problem. Large ASDs in small children, inability to accommodate. You can see this. Even before opening the left atrial disc, it is almost prolapsing across the defect. So this is a small left atrium and a large left atrial disc of an 18 millimeter device. You can see just coming across. So lack of accommodation resulting into lack of alignment and herniation of the device. So in order to overcome this, we described a group of techniques, what we called as left atrial disc engagement, disengagement techniques. The principle is simple: engage the left atrial disc, release the waist, followed by the release of the right atrial disc. And because of the tension of the cable, there is a spontaneous disengagement of the left atrial disc with the device capturing all the rims and sitting beautifully across the defect. So this is the left atrial disc being engaged in the left superior pulmonary vein. We release the waist, then we release the right atrial disc, and the left atrial disc has spontaneously disengaged itself, and you can see how beautifully the device is lying across the defect. And this is a real life picture of this left atrial disc engagement disengagement technique with engagement done in the left superior pulmonary vein. So the thing is that there is nothing sacrosanct about the left superior pulmonary vein, and you can engage the left atrial disc into RSPV, left atrial appendage, or left atrial roof. Sometimes this happens accidentally, and I'll show you some of the examples. So this is how it looks on transesophageal echo, the engagement disengagement technique. I think this is a very important question. When there is a failure to disengage the left atrial disc spontaneously, should you be pulling on the cable or pushing? Majority of the folks will say that pulling on the cable is logical, and that's usually what you do as an instantaneous reaction. You see that you are pulling, but in doing so, you lose the alignment of the right atrial disc with the interatrial septum, and both the discs now are malaligned with the plane of the interatrial septum, and they drop across the defect into the right atrium. So what we do actually is a little contrarian. Rather than pulling, we push on this disc. And you see now the vector of this force, which is looking downwards, helps in pulling out the left atrial disc from the left superior pulmonary vein. And not only left superior pulmonary vein, you can help by pushing on the cable to get the left atrial disc out of the right superior pulmonary vein. You see here, but this push has to be extremely gentle, and it has to be in the upward direction and not facing towards the pulmonary vein, because then you will be traumatizing the pulmonary vein. However, despite all these tips and tricks, you can have problems of left atrial disengagement technique. You can have failure to disengage. Sometimes there is a premature disengagement. And sometimes while pushing on the cable, both the discs may get pushed into the left atrium. So I'll show you just a couple of examples. We were trying to engage in the left superior pulmonary vein. There was a premature disengagement, but the disc got engaged into the left atrial appendage. And we used that engagement to deliver the device. Similarly, while coming out of the right superior pulmonary vein, we came out a little prematurely, but it got engaged somewhere in the roof. And we use that engagement to deliver the waste and the right atrial disc, and here it goes. So the device sits beautifully across the interatrial septum. The same case, when we are trying to make use of that accidental engagement while pushing on the cable, both the discs went into the left atrium, like it happened with balloon assist technique. Here again, the alignment of the left atrial disc is so good that we just had to pull it back, and that was how it looked. And this is a beautiful placement, and then we release the device. These are last two slides. So these are some of the complications of left atrial disc engagement, disengagement, failure of the procedure, as I said earlier. You may knock on the AV node, cause AV blocks, or injury to the pulmonary veins, acutely resulting into bleeding and chronically in pulmonary venous stenosis. Fortunately, we did not have either of them. In conclusion, ladies and gentlemen, routine technique of device deployment has limitations. There are multiple techniques available. And given our current experience and expertise of large number of groups across the world, I think technical success is coming close to 100%. However, all technical success does not translate itself into clinical success. Embolization, arrhythmias, thrombus formation, and erosion continue to remain problems. So I will leave you with this message now that we can, or rather this question, now that we can, whether we should. Thanks for your patient hearing, and sorry for this delay.